Dyslipidemia in adults. This is an educational review video intended at improving clinical practice of primary care nurse practitioners and a knowledge review for nurse practitioner students and any students in healthcare. I'm Jibi, currently working as autonomous nurse practitioner in Right Focus Healthcare LLC. Regarding my clinical experience, I was a pulmonary nurse practitioner for 3 years, primary nurse practitioner for 1 year, and RN in cardiology units for 16 years. What is dyslipidemia? Dyslipidemia is a broad term refers to an abnormal level of blood lipids, including high levels of LDL or low density lipoprotein cholesterol, triglycerides, and low levels of HDL, which is high density lipoprotein cholesterol. For the students, I will explain each of them in another slide. What is the epidemiology of dyslipidemia? Dyslipidemia is a global health problem that affects millions of people and increased risk of cardiovascular disease or atherosclerotic cardiovascular disease, which we call ASCVD, the term you're going to hear more in the next slides. According to WHO of 2023, 39% of world adult population affected by elevated blood cholesterol. Dyslipidemia affects 33% of adults in United States. Prevalence, the occurrence of dyslipidemia varies by age, sex, and ethnicity and influenced by genetic and environmental factors and plus dietary factors. Men have higher prevalence than women. Dyslipidemia is asymptomatic and coexists with other risk factors, hypertension, diabetes, obesity, and smoking, which leads to high cholesterol. And per 2019 studies, high LDL contributed to 44% ischemic heart disease death and 22% ischemic stroke death. So because of this reason, dyslipidemia is asymptomatic and can lead to death. It's very important for providers to educate patients to have regular screening of lipid levels. Types of dyslipidemia: primary dyslipidemia and secondary dyslipidemia. Primary dyslipidemia occurs in individuals with specific inherited traits or gene mutation which results in defects in lipid metabolism and transport. There are 4 types. It can be inherited as an autosomal dominant, recessive, or X-linked. One example is familial hypercholesterolemia, which is 1 in 500 prevalence in most population, caused by mutation in LDL receptor genes, impairing the cholesterol uptake from blood and results in atherosclerosis. Another one is familial combined hyperlipidemia, which is estimated 1 in 100, which can be higher in patients with the premature coronary artery disease. Secondary dyslipidemia is due to the lifestyle factors or medical conditions. The good news is that it's reversible if you treat the underlying cause. Obesity, physical inactivity, high dietary saturated fat, cholesterol, carbohydrate, and calorie intake. Obviously, this is by the diet correction. Then endocrine disorders like diabetes mellitus, the insulin resistance, and the hyperglycemia, which will block the triglyceride lipolysis and the uptake of the LDL cholesterol, which leads to all altered lab values and dyslipidemia. Then hypothyroidism, there is decreased LDLR receptor expression and decreased lipoprotein lipase, which lead to decreased clearance of LDL and triglycerides from the blood. In chronic kidney disease, there is decreased activity of lipoprotein lipase, so there is impairment of the clearance of the cholesterol from blood. Then, in hepatic disorders like liver disease, impaired synthesis and secretion of lipoproteins and bile acids, which impair the transport and excretion of cholesterol and triglyceride from the liver. This is very important when you prescribe the nonstatins. The immunological disorders, which is SLE or systemic lupus erythematosus. There is decreased production of HDL or there is dysfunctional HDL, which leads to dyslipidemia. Then the medications: corticosteroids, beta blockers, oral contraceptives, antiretroviral agents can affect the metabolism of lipoprotein, leading to altered dyslipidemia. Pathophysiology of dyslipidemia. Considering the students, I will explain the pathophysiology in a basic level. As you see in the second picture, cholesterol is naturally made by the body, by the liver, and also it's obtained from food. And it's needed for body for energy and steroid production and bile acid formation, but the excess can be harmful. And in the second picture, you see the good cholesterol, bad cholesterol, type of cholesterol, healthy blood vessel. Cholesterol travels through the body and is carried by lipoproteins or carriers. So high density lipoprotein, HDL, which is the blue in color, good cholesterol. And you can see in the healthy blood vessels, there is a lot of blue in there. And then there is LDL, low density lipoprotein, which is bad cholesterol. So the HDL, why it's called a good cholesterol? Because of their low fat and they carry cholesterol or lipids to the liver for degradation away from the blood vessel. While LDL, the bad cholesterol, as you see in picture, are harmful because they keep cholesterol in the blood vessels, forming fatty deposits. As you see in the picture, the yellow part, and which is atherosclerosis. And next, the third one, very low density lipoprotein, serve as a precursor of LDL. What that means, when there is increased VLDL, it leads to increased LDL. Next, fourth one, the triglycerides. They store unused calories and provide body with energy. But so triglycerides are not directly atherogenic, but represents a cardiovascular risk. As you know, triglycerides are mainly from carbohydrate or calorie intake. In the third picture, you can see the healthy artery, there is no plaques. Then the second picture, beginning cholesterol plaque, you can see that the LDL is getting deposited into fatty deposits or plaques. So why the lipid screening is very important even in healthy patients, because these stages the patient is asymptomatic. Even in the advanced cholesterol plaque, there may be signs of peripheral artery disease, but still patient may be asymptomatic. Then comes the complete blockage, which there is no more blood flow possible in the blood vessel because there is too much accumulation of the plaques. So it leads to complete blockage, which leads to MI or heart attack or ischemic stroke. How to diagnose dyslipidemia? As in any other medical condition, first, history. Ask the patient about previous or present cardiovascular disease, which includes MI, angina, coronary artery procedures, or bypass surgery, and then CHD risk equivalents like PAD, peripheral artery diseases, and abdominal aortic aneurysm, carotid artery disease, and then inquire about presence or absence of risk factors, which we can remember in a mnemonic SAD, CHF, smoking, age, diabetes, cholesterol, hypertension, family history. Then inquire about their medications. Remember in the etiology, the drugs that elevate cholesterol, diuretics, beta blockers, corticosteroids. And then remember the etiology, ask about past medical history, including pancreatitis, renal disease, liver disease, vascular disease, endocrine disorders, and immunological disorders. And then ask about any abdominal pain, and then amount of alcohol consumption if applicable. And then a female, ask about menstrual history and any type of hormone replacement if applicable. And then very important, ask about intensity of physical activity and then the typical diet over a 24-hour period. You can assess the intake of LDL in their food by a mnemonic cafe. C for cheese, A for animal fat, F for fast food or restaurant, and E for extra foods like cookies, pastries, and donuts. Next is physical examination, measure blood pressure, measure height and weight and BMI, and then palpate thyroid, and then complete heart and vascular exam, and then abdominal exam, exclude hepatomegaly or splenomegaly, and then observe skin for any xanthomas. As you see in the picture, this is only for the students. They are not clinically significant. Xanthelasma in the first picture is a benign condition, cause flat flat or yellow-white deposits to appear on the eyelids. These deposits are a type of cholesterol deposits, though people with this asthma does not have to have abnormal lipid profile. Then second picture, arcus senilis, it's a blue or white hole ring around the cornea of the eye. It's caused by fatty deposits, primarily cholesterol, building up on the cornea of the eye. It's normal in older people. Then third picture, it's a firm yellow dome-shaped papules in the arm of a 46-year-old man with a hypertriglyceridemia and a hypercholesterolemia. Regardless, these pictures are for the students, and these are not clinically significant. Lipid screening is the accurate tool for diagnosis of dyslipidemia. As I mentioned in the previous slide, the accurate diagnosis of dyslipidemia is by assessing lipid profile. There are different screening guidelines by different association. Based on the population type, the primary care practitioners have to do. Clinical Endocrinology Association recommends all these population group annual screen adults with a diabetes mellitus. Then young adults, male 20 to 45 years, females 20 to 55 years, screen every 5 years. Middle-aged adults, male 45 to 65 years, female 55 to 65 years, screen at least every 1 to 3 years. Older adults greater than 65 years, screen annually. And order a fasting lipid profile if possible. Then let us check the numbers, ideal numbers of each parameters: total cholesterol, LDL, HDL, and triglyceride. The ideal total cholesterol less than 200, LDL less than 100, very important. HDL, which is a good cholesterol, should be greater than 60. And then triglyceride, important, less than 150. Then borderline, total cholesterol 200 to 239, LDL 130 to 159, HDL women 40 to 59, men 50 to 59, triglycerides 150 to 199. Now let us check what is too high or too low, which is above the borderline. Total cholesterol greater than 240, LDL high 160 to 189, very high greater than 190. Very important number when we discuss the treatment. Then HDL too low, women less than 40 or men less than 50. So the HDL should be above 40 for women and above 50 for men. Then triglycerides high 200 to 499, very high greater than 500. Very important number because it can be a sign of pancreatitis other than the risk of cardiovascular disease. Next is dyslipidemia screening guidelines. There are different guidelines by different associations. US Preventive Services Task Force recommend lipid screening for high-risk men aged 20 to 35 and high-risk women aged 20 to 45 years. And in general, men 35 years and older and women 45 years and older. And fasted lipid profile for all individuals who are between 20 to 78 years, at least every 5 years, if no risk factors or atherosclerotic disease is present. American Heart Association and American College of Cardiology recommendations for cardiovascular assessment guidelines. Routine lipid screening for patients between 40 to 75 years every 4 to 6 years. Diabetes mellitus or history of cardiovascular disease need more frequent assessment. Number 2, very important because I use American Association treatment guidelines in this video, so it's very important to listen to the percentage. Use a risk calculator to estimate the 10-year ASCVD risk, which include coronary heart disease, stroke, and peripheral arterial disease. The risk calculator accounts for, you can remember a mnemonic: SAD, CHF, age, sex, race, total cholesterol, HDL, systolic blood pressure, antihypertensive therapy, diabetes, and smoking status of the individual. The age, men greater than 45 and women greater than 55 is a risky one. The risk categories are low risk, less than 5%, borderline risk, 5 to 7.4%, intermediate risk, 7.5% to 19.9%, and a high risk greater than 20%. For the nurse practitioners, primary nurse nurse practitioners, while you're talking to the patients, there is an app in the iPhone, ASVD Risk Estimator Plus, very, very useful, because while you're talking to the patient, taking the history, you can even calculate and have an accurate ASVD risk percentage, which helps in the decision making of whether they need to be on drug therapy or not. Next is steps of dyslipidemia treatment. First, assess the patient's ASCVD risk. Number two, nurse practitioners should know the LDL goal in each group of patients. Number three, determine the patient will qualify for a drug therapy or just advise therapeutic lifestyle changes. The picture in the slide is American Association Dyslipidemia Treatment Guidelines. I use this to explain the LDL goal just to understand the treatment better, and I will explain medication in the treatment slides. The first picture is a secondary prevention in patients with the clinical ASCVD, and in the first section you can see ASCVD not at very high risk. What are these patients? Are the patients with a history of MI, stable or unstable angina, coronary or other revascularization procedures, history of stroke, TIA or PAD, peripheral artery disease, or aortic aneurysm. So the next group, so in that group you can see that age less than 75 or greater than 75, the LDL goal is less than 70, and the different colors are just the different type of medications, whether it's statin or pcsk9 or ezetimibe. And then the next group, very high risk ASCVD, those are patients who had a major ASCVD event or multiple major ASCVD event, like the cabbage coronary artery bypass graft or angioplasty, and with the high risk conditions like familial hypercholesterolemia, chronic kidney disease stage 3 or 4, diabetes, hypertension, history of congestive heart failure, current smoker. So in those patients also the LDL-C goal is less than 70. You see the two different colors is for consideration of PCSK9 or adding ezetimibe. And then there is a goal non-HDL-C less than 100. What is non-HDL-C? It is the total cholesterol minus the HDL-C. It is all the bad cholesterol that is not carried by HDL particles. So that should be less than 100. Next is the second picture is primary prevention, and you see that the upper right, two of them, LDL-C greater than 190 and diabetes age 40 to 75 years, they recommended drug treatment, no risk assessment. And risk assessment in the second group is only to differ whether high intensity or moderate intensity statin. And then the third group, age 40 to 75 years and LDL-C 70 to 190, you see 4 columns, and 5 to 20%, second, third and fourth, need drug treatment. And in the 5 to 7.5%, there is a risk discussion or whether assess the risk enhancers presence or not. And then less than 5%, lifestyle change only. Then comes age 20 to 39 year. Their LDL goal is less than 160 and advised drug therapy if there is a family history of premature ASCVD and LDL-C greater than 160. Next is therapeutic lifestyle education. Initiate therapeutic lifestyle change if LDL-C is above goal, regardless whether the patient was started on drug therapy or not. First is dietary modification. Recommend to the patient a diet rich in fruits greater than 2 servings per day, vegetables greater than 3 servings per day, like broccoli, carrot or Brussels sprouts, and greater than 1 serving at least dark green vegetables, and encourage whole grains, meals, legumes, high fiber cereals, low fat dairy products, and poultry without skin. Total fat in a diet may range from 25 to 35% of total calories. American Heart Association recommends that the saturated fat only should be less than 6% of the total calories. As you see in the picture in the screen, there are saturated fat and trans fats. On the upper section are bad fats, and the bottom fats, the monounsaturated fats and polyunsaturated fats, are better fats. So what that means, only less often the saturated fat should be taken or avoided, like beef, pork, red meats, and palm oil and coconut oil, and cheese, butter, whole cream milk. Then avoid trans fats like donut, cookies, deep fried items, and fries. Then encourage more monosaturated fat and polyunsaturated fat, like encourage avocado. And there are a lot of oil varieties: canola oil, corn oil, grapeseed oil, olive oil, peanut oil, safflower, sesame, soybean, and sunflower. And then encourage nuts like almond, flaxseed, pumpkin seed, peanut, hazel, and sunflower seeds, and walnut. And American Heart Association recommends 8 ounces of fish each week. Encourage fish like mackerel, sardine, and salmon. Next, physical activity. Encourage patients to do more physical activity. American Heart Association suggests adults should have 150 minutes of moderate intensity aerobic exercise like brisk walking, cycling, or swimming, or dancing, and 75 minutes of vigorous intensity activity like running or playing sports or gym, and that increases the endothelial function and reduces the inflammation and prevent the thrombosis. So educate the patients about that. And next is weight management. As you know, the BMI ideal is 18.5 to 24.9. So if the patients are obese or who are overweight, they aim for a gradual sustained weight loss of 5 to 10% of their body weight over 6 to 12 months. Then the smoking cessation. Smoking cessation, give them different options to quit, like nicotine replacement, and educate them about it. Improves the low lipid profile and lower blood pressure, and decrease the cardiovascular disease and other chronic disease. Lipidemia treatment, statins. In the treatment slide, I have mentioned about the medications used in the treatment: statins, pcsk9 inhibitors, and sedimib. Out of that, the most important one is statins. Let us review the classification and mode of action and side effects of statins. The classification of statins: high intensity, moderate intensity, and low intensity. The high intensity statins are atorvastatin and rosuvastatin, or Lipitor and Crestor, and it lowers LDL greater than 50%. And atorvastatin, the dosage is 40 milligram to 80 milligram, and atorvastatin to rosuvastatin 20 milligram to 40 milligram. Out of that, the rosuvastatin is the potent one because the maximum dose is 40 milligram. Then moderate intensity statin lowers LDL 30 to 49%, which atorvastatin and rosuvastatin, the maximum dosage is 20 and 10. And other statins: lovastatin 40 milligram, simvastatin 20 to 40, pravastatin 40 milligram to 80 milligram, which is a higher dose. You can see that. And then low intensity statins lowers LDL less than 30%, which we don't use atorvastatin or rosuvastatin in that case. Lovastatin 20 milligram, simvastatin 10 milligram, pravastatin only 10 milligram to 20 milligram. And then the mode of actions of statin. Statin blocks the enzyme, as you see in the picture, HMG-CoA reductase enzyme, which involved in the production of the cholesterol. And also you can see that it increases the LDL receptors on the surface of the liver cell, so that is more cholesterol is absorbed from the blood. And then let's other actions, other important things about pharmacological important things about statins, be it's contraindicated in active or chronic liver disease. And then use with the caution if patient is on cyclosporin, gemfibrozil, niacin, and antifungal agents. And instruct the patient not to take with the grapefruit juice, because that prevents the enzyme CYP3A from breakdown of the statins in the intestine, so that increases the statin level in the blood. Also instruct the patient to take statin in the evening or at bedtime. That's the time statins effect is more. And then let us discuss about the side effects of statins. You can remember that in a mnemonic, Lipitor, L is liver effects. That's why we check the liver enzymes periodically that we already discussed. I, increased blood sugar, pain, muscle pain, which is a common complaint of the patients. And there are two types of statins, lipophilic and hydrophilic. The hydrophilic ones are rosuvastatin and pravastatin, which we can remember by thinking remove pain. So we can switch to those statins. Then I, impaired memory, T, tiredness, O, other like headache or nausea, R, rhabdomyolysis. Rhabdomyolysis is a medical condition which involves rapid dissolution of damaged or injured skeletal muscles. So the patient will complain of muscle pain or weakness, and there will be tea-colored urine. So you can advise a patient, as soon as you see that, stop statin, and we check the CK level, and if the CK level is greater than 5,000 per international unit per liter, there is significant muscle injury. But we can educate the patients that when you compare advantages and disadvantages of statins, advantages outweigh the disadvantages. There is reduction of cardiovascular event, 10% in primary prevention and 5% in secondary prevention. And also in patients with the diabetes, there is the study shows there is 24% of cardiovascular events, and there is benefit of preventing 16% mortality. While the side effects or the disadvantages or the reported per studies and shows that the liver injury is 1 in 100,000 cases, hemorrhagic stroke 0.5 per 1,000 patients, diabetes 10 to 20 per 10,000 patients, and impairment of memory is not 100% proven. Myotoxicity 10 to 20 cases per 10,000 statin treated patients, and muscle pain 3 to 33%, and 1 in 10,000 patients increases CRP, and 2 to 3 per 100,000 patients there is occurrence of rhabdomyolysis. So we can educate the patients the statin benefits are more compared to any kind of side effects. Next is pcsk9 inhibitor. There are two of them, Repatha and Praluent. Repatha evolocumab is 140 mg per ml. Praluent alirocumab is 150 mg per ml and 75 mg per ml. Both of them, the frequency is once every Q2 weeks to once a month. And the advantage over statin, not so much myalgia reported, and then the side effects are hypersensitivity reactions or injection site reactions or common side reactions. Then it's indicated on patients mainly primary hyperlipidemia and familial hypercholesterolemia, which we already discussed. The bad side of PCSK9 inhibitor is that the Repatha is like about $600 and Praluent is like $500, and it's very expensive. So if there is any statin intolerance, maybe some of the insurance may cover it. Next is a mechanism of action of PCSK9 inhibitor. You can see on the right side picture there are two sections. The mechanism without a PCSK9 inhibitor on the right side, and then there is a left side PCSK9 inhibitor action. So normally what happens is that when the PCSK9 will bind with the LDL receptors, which you see on the surface of the cell and the liver, the receptor is degraded at the lysosome level, and then it's not available for recycling. While when you can see on the left side, the first section, there is pcsk9 inhibitor, which is a monoclonal antibody against pcsk9. So that inhibits the binding of the pcsk9 and LDL receptor. So the binding is not happening. So LDL receptor doesn't degrades. So it is available for recycling, and then it increases the expression of the LDL around the cell surface, and it's available to take the cholesterol uptake and thereby lowering the serum LDL-C levels. Next is non-statin medications. Non-statin therapy reduces lipid profile level but not proven to reduce cardiovascular mortality. The exception is ezetimibe in the list. It can reduce cardiovascular risk diseases. Then let us look at the list. The bile acid sequestrants, ezetimibe and bempedoic acid reduces LDL 15 to 25%. Niacin and fibrates only 5 to 20% LDL reduction, 5 to 15% reduction respectively. But the fibrates have advantages. It reduces triglycerides 25 to 35%. Now let's look at the picture. As you see, ezetimibe reduces cholesterol absorption from the intestine, so it helps in the dietary cholesterol, and the LDL reduction is 15 to 20%. The combination of simvastatin 40 milligram and ezetimibe 10 milligram is a popular medication by Taurine. So the advantage of the medication is it affects two-way, reduces cholesterol production in liver, and then the reduces the absorption of the dietary cholesterol. So the advantage over statin, it reduces LDL 47 to 59%. The disadvantages of Vytorin are already simvastatin is a lipophilic statin, so together with ezetimibe it can cause myopathy. And then there is upper and lower GI complaints, which is rare, and there is a contraindication. It cannot be used in active liver disease, the ezetimibe. Back to a list of non-statin medications. When the cholesterol is elevated and monotherapy does not achieve goal, the combination therapy are statin plus bile acid sequestrant, statin plus ezetimibe, and statin plus niacin. And when the patient has mixed dyslipidemia like high triglycerides and low HDL, the combinations include statin plus niacin, statin plus bile acid sequestrant, or ezetimibe plus fibrate, or ezetimibe plus niacin. So the first in the list is bile acid sequestrants. It impairs the absorption of the bile acids. So the liver has to produce more bile acids. So it uses the cholesterol to do that. So thereby reduces the cholesterol level. And then it's available in 5-gram packet or 1-gram tablet. And if it is not taken with enough water, it can cause constipation. And it's not a choice for the patient who don't want to use packets. And it's a medication safe for pregnant women or lactation women because there is no systemic absorption. The medications are cholestyramine, Velcol are examples. And we have to be very cautious when the patient has triglycerides greater than 200. The patient can go to pancreatitis. Next is Cedia, we already discussed, and bempedoic acid. It's a choice when the patient have statin intolerance, but look at the side effects. Increased uric acid can lead to gout and then tendon rupture, so maybe not a frequent choice. Then niacin. It's available in 500 milligram HS. It reduces VLDL, so thereby reduce the LDL. And the side effects are very much the hyperglycemia, hepatotoxicity, hyperuricemia, so that make it less preferable. Then next is fibrates. In the combination medication, the latest guidelines not recommend fibrates plus statin because of the risk of rhabdomyolysis. Next is fibrates. The examples are gemfibrozil, 600 milligram twice daily. You take it 30 minutes prior to morning and evening meals. Tricor, 48 to 145 milligram daily. The side effects, increased effects of anticoagulants, and can cause gallstones. This is a drug of choice. When we see a lot of patients in the clinical settings, their all lipids are normal except the triglycerides, and they tried dietary changes, but they cannot make a significant diet change. So the Tricor is a good drug to go because that helps the triglycerides to become normal. Another point, just like statins, all these medications need the liver enzymes to be checked periodically. Next is dyslipidemia treatment guidelines. There are different guidelines by different associations: Canadian Cardiovascular Society, European Society of Cardiology. The picture in the slide is American Heart Association's guidelines for dyslipidemia treatment. Since we already discussed the treatment goals, the LDL goals, plus all medications, side effects, mechanism of action, and definition of the all-risk patients group, it's easier to understand the treatment by the chart. First, you can see in the picture that is a picture of secondary prevention of clinical ASCVD algorithm. And there are two groups of patients, ASCVD not at very high risk and ASCVD very high risk. I already explained which patients belong to each group. ASCVD not at very high risk, age less than 75. We recommend high intensity statin. The goal is to reduce LDL greater than 50%, and if patient cannot tolerate, advise moderate intensity statin. So the high intensity statin, again, you can see in the chart, atorvastatin 40 milligram to 80 milligram, rosuvastatin 20 to 40 milligram. And if to moderate intensity statin, either reduce the dosage of those statins or use popular ones, pravastatin 40 to 80 milligram moderate intensity statin, and simvastatin 20 milligram to 40 milligram. Then if still the LDL-C is greater than 70, they are recommending to start ezetimibe. Now, age greater than 75, the second section on the first chart, they are advising moderate or high risk statin, not recommending aggressive treatment. Next is the right side, the second part is very high risk ASCVD. I already discussed, but just to memorize, these are patients who had 2 to 3 major ASCVD events. The reason is, for example, recent ACS within past 12 months and a history of MI not included that event, history of ischemic stroke or symptomatic PAD, or with the high risk conditions like hypercholesterolemia or a prior coronary artery bypass surgery, diabetes, hypertension, history of congestive heart failure, chronic kidney disease stage 3 or 4, and with current smoking. In these patients, the recommendation is high intensity statin, again atorvastatin and rosuvastatin. I already discussed the dose, and if for maximal statin, still the LDL is greater than 70, they are recommending adding ezetimibe, and still if the goal is not reached, so they are recommending to add pcsk9, which remember the two of them, Rapata and Praluent, to achieve the LDL goal of less than 70 and non-HDL less than 100. Next group is in the picture on the top right. There is the first row, patients age greater than 21 years and LDL is greater than 190. So in those group, even the risk assessment is not needed. The LDL reduction goal is greater than 50%. So high intensity statin. Again, high intensity statin is in the table. Rosuvastatin 20 milligram to 40 milligram, atorvastatin 40 milligram to 80 milligram. And if there is any safety concern, use moderate intensity statin. And they are advising adding non-statins statins if the LDL goal is not achieved. Next is in the algorithm table, the top second row, the patient with a 40 to 75 years, no ASCVD, but the patient is diabetic and the LDL is 70 to 189. In that case, if the 10-year ASCVD is greater than 7.5%, consider high intensity statin, otherwise moderate intensity statin. So in that group, the only the risk assessment is only for decide between high intensity and moderate intensity statin. Anyway, that group diabetic and no ASCVD and LDL 70 to 189, that patient definitely need a statin. Next group is in the treatment algorithm picture. There is 4 columns. Adults aged 40 to 75 years without ASCVD or diabetes. So no ASCVD, no diabetes, but LDL-C 70 to 189 and an estimated 10-year risk of ASCVD of greater than 7.5%. So 7.5% to 20% both, you can start the patient on high intensity statin. And then the second column, 5 to 7.5%, greater than 5 to 7.5%, borderline risk, so patient consider moderate intensity statin. And then the first column, less than 5%, low risk, so risk discussion and assess any risk factors, and then based on that decision making, no statin is advised. Then the group that we didn't discuss so far is age greater than 75 years, clinical assessment and risk discussion. And then the age 20 to 39 years, the LDL goal is less than 160. So the drug therapy is advised if the LDL is greater than 160 or there is any family history of premature ASCVD. Updates and other points than the 2018 dyslipidemia guidelines. Lipoprotein A level should be measured once in a person's lifetime as a part of initial screening. Lipoprotein A determined by genetic and not affected by diet or medication. So the normal value is less than 30 milligram per deciliter. Advantages is that we can identify early hereditary dyslipidemia and the patient can be on medications like pcsk9 inhibitors. Then next one, coronary artery calcium scoring for patients with intermediate risk. If coronary artery calcium score is 0, we can withhold the statin unless the patient is in high risk, include cigarette smoking, family history of premature ASCVD, diabetes, and if the score is 1 to 99, risk discussion, and if the score is greater than 100, patient statin therapy is recommended. Then another one, the apolipoprotein B, which is a component of LDL and VLDL, and non-HDL cholesterol is getting now more important than LDL cholesterol in screening and monitoring. Then all women with a history of gestational diabetes or low birth weight infant or hypertensive disorder should be screened with a complete lipid panel on late postpartum period. Next one, avoid recommend omega-3 polyunsaturated fatty acid supplements for cardiovascular risk reduction. Next is when to do referral for dyslipidemia or when to consider referral. Very high risk ASCVD, uncontrolled diabetes and dyslipidemia coexist, abnormal lipid levels despite intensive treatment, peripheral vascular disease, hereditary or primary dyslipidemia disorders. For primary care nurse practitioners, most of these patients would have already cardiology on board who are experts in lipid management. So we can refer to them, and if they think need referral, there are hospitals, 1 or 2 in a county with lipid specialists working only on lipid management. Next, what are the complications of dyslipidemia? The most significant one is cardiovascular disease, which leads to acute myocardial infarction and sudden cardiac death, which I already explained the pathophysiology section. Then stroke another complication. Then high triglycerides can cause acute pancreatitis. Next is a follow-up of dyslipidemia patients. Evaluate patients on therapeutic lifestyle changes every 6 weeks until LDL-C level treatment goal is reached. I have discussed already, patients with a clinical ASCVD or high-risk ASCVD, LDL goal is less than 70. For patients age 40 to 75 years and diabetes, LDL goal is less than 70. And for patients whose LDL is greater than 190 or age 40 to 75 years, ASCVD risk is greater than 7.5%, those patients needs to be on aggressive treatment. Number 2, once LDL optimal goal is reached, patient evaluation every 4 to 6 months. Number 3, check lipid profile every visit. Number 4, very important, for patients on statins, fibrates or niacin, we have to check liver profile before initiation of those medications and 3 months and 6 months after initiation. About prevention and patient education of dyslipidemia, I have already explained in therapeutic lifestyle change education. Focus the patient education on 4 topics: dietary management, physical activity, weight management, and smoking cessation. Please listen to those slides and learn how to educate patients on therapeutic lifestyle changes based on their LDL goal. Hey, thank you for listening to my educational video of dyslipidemia in adults for nurse practitioners. I hope this will improve your clinical practice, especially primary care nurse practitioners. And for the nurse practitioner students, this will add to your clinical knowledge. And this was a vast topic. If any content is missed, please email me rf@cllcmedcompany@gmail.com. Thank you again.